How is everything in Jabalpur?
Sir, the winter is just starting and it was a very long summer this time and not as much rain as we used to have every year, but now winter has started.
And how about pollution in the city? Lahore is very bad.
Sir, we are relatively, how should I put it, not a very industrialized part of the country. So that pollution which comes with the development of industries, that is not with us, not too much.
Okay, right. So we can start whenever you feel like. We are all set. There are a lot of people who are online in other parts of the country.
Sir, I can see only 4 participants right now.
I think because there is a change of the link, so I think we have just this morning sent the link to most of them. So,
sir, would you like to wait for a few minutes or should we start?
we can wait for 3, 4, 5 minutes and then get on with it.
Great, sir. How was your trip to Colombo? All went well? How's your health?
It was very nice. It was most of it was online lectures, but we had then we had a lot of meetings with the Royal Colleges. I'm international advisor to the Royal College of Physicians Surgeons of Glasgow. So we met.
Yes, sir.
We met the incumbent president and the president, who is taking over in 10 days' time. So we sorted out a lot of things of honorary fellowships and made a committee, including myself, from whole of the world, people who apply, and we'll be scrutinizing along with a chap who is the vice president. His name is Abe Rane from Pune.
Yes, sir.
He's based in Sussex, and he's the one who is the vice president. So myself and Abhay would be looking after this fellowship, honorary fellowship and membership all over the world.
Sir, we are bringing out a special issue of Indian Journal of Surgery, and I am the guest editor. It is focused on surgical education and academic surgery, sir. It will come out, I think, next month.
Okay, right.
And I had requested the Glasgow College, and Abhay has contributed one very nice article, how Glasgow College goes about the surgical education and postgraduate training, how they set up the standards, how they examine.
He's a very decent young man based in Sussex, London. And it was a really pleasure to meet him. So we are in touch with him day in and day out. I think we can start off. People will keep on joining.
वो आ गया, मैंने उन्हें कहा है किधर है यहाँ पे उनको जगह नहीं पता था तो आई मैसेज देम टू कम ओवर हियर.
Another 2 minutes and we'll get on with it. So.
Right, sir. I'm ready. Good morning, sir. Sheikh Saab, good morning. How are you? Good to see you, sir. Good to see you.
Thank you, sir.
Okay.
बस ज्ञान का सारे में प्रैक्टिस करना मुश्किल है. Obviously, going to open. नाले फॉग भी है ना, रास्ता भी आज नहर का रास्ता स्लो सी, दो जगह ब्रेक डाउन सी। 15 मिनट में फिर इकट्ठा ऐसा होता नहीं है, ट्रैफिक तो आधा घंटा
तो बिफोर टाइम एक काला शक काफी इंसिडेंट हो गया 100 गड्डियां पे 30+ दैट्स नहीं गड्डियां का कल हुआ परसों सियालकोट मोटरवे पे हुआ
सही, उस स्पीड बड़ी होती है ना,
असले इतने ब्रेक लगाई ना कि अचानक ਉਹਨੂੰ ਨਾ ਨਜ਼ਰ ਆਇਆ ਪਿਛਲੇ ਫਾਲੋ ਕਰ ਰਹੇ हैं।
Right, sir. I think we have all the heads of departments of surgery here. Now I'll ask them to introduce themselves, and then we can start off with starting Professor Zahid. Mask niche kar le.
Good morning, sir.
Good morning, sir. Nice to meet you, although virtually. Nice to meet you.
Professor Asnat Ahmed and Department Surgical Unit 2.
Good morning, sir. Good morning.
Professor Shaukat Rabbani, Department of Surgery.
Good morning, sir.
Morning, Dr. Imran Indrawi and Professor Said. Unit 2.
Good morning, sir.
Morning.
बोलते जाओ आप लोग।
Dr. Mohammed Kaleem, postgraduate training, Unit 2.
Good morning, sir. Good morning, sir.
Dr. Sadhar, Associate Professor of Surgery.
Namaskar, madam. Namaskar.
Dr. Abrar, Senior Registrar of Surgical Unit 2.
Second.
Good morning, sir.
Sir, thank you.
Shakib Zahoor, Professor of Surgery, Surgical Unit 1.
Good morning, sir.
Good morning. Sir, Dr. Rangs, Resident Surgical Unit 1.
Good morning, sir.
Zamir Mushtaq from IT.
Zamir Saab, good to see you after a long time. Good to see you.
Thank you, sir. Thank you.
Dr. Ima Tawassum, Resident Trainee of Surgical Unit 1.
Namaskar, madam. Namaskar.
Dr. Wakar, Resident of Surgery Unit 1.
Good morning, sir.
So I think let's get on with your presentation, and thank you very much. I was just telling my staff here that Professor Dhananjay Sharma is a very, very capable man, and he has done so much work, and so we are really honored to have you online. And just for everybody's knowledge, he is also visiting professor of Lahore Medical and Dental College. Thank you, sir, for honoring the college.
Thank you, sir, for your kind words and your invitation. As always, I bring goodwill from my association and my college. We have deep roots of friendship with the Pakistan College, and always a pleasure to see all the colleagues, sir.
Thank you.
So I have today chosen to speak on this topic, which is very close to my heart: low-cost surgical ideas which prove successful. And this is my 41st year in surgery, sir. So last 4 decades, we have learned, all of us have learned a few lessons which the textbooks have not taught us, but the life has taught us. So I'll be very happy to share some of these ideas with you.
Good.
So this is our philosophy, sir. When resources are not available, we try to find a low-cost solution, sir. And this is my college, the department, sir, and I have been heading for it for now 15 years. And this is what we want to do. This is what our training also includes: find a low-cost solution. And how do we go about it? Sir? The word global.
Can't see the slide, sir.
But I'm screen sharing, sir. Can you see the slides?
Yes, we can see your first. I can see your first slide, but the slideshow is not working properly.
Sir, Uzair को drive भी करना चाहता हूँ.
Is it okay now? Is it okay now?
Gee, we can see the screen.
This one?
Yeah, the first one.
Is the slide visible, sir, now? Screen?
Yes, yes, it is.
Okay, should I go on?
Gee, please carry on.
Okay, sir. So the word global has become a very key word, and it's a buzzword. Everybody likes global warming, global this, global that. In my view, sir, global means together. And we have to join hands to find a solution to our problems, and together. So what I interpret is global wisdom. We learn from everyone. Everyone has ideas, but because we are working in developing countries, we have to use local resources. So I have coined this word global and local. I think the word is glocal. Glocal describes our philosophy. We learn from everyone, but we use our own resources. So let's see what global wisdom we have. Very few surgeons have received Nobel Prize. Joseph Murray, I think, was the last one who got it. And this was the plaque on his table. Difficulties are opportunities. We all face difficult situations. We should try to convert them into opportunity. And if we solve those problems, our patients will benefit and we will also benefit. Next, wisdom also comes from a Nobel laureate. We can do research on what is interesting or what is important. It is very interesting. I would love to do a cardiac transplantation in the morning and find a vaccine for cancer in the afternoon. Can I do that? That will be very interesting. But I have to focus on what is important for my patients. Perforation peritonitis, strangulated hernia, things like this, which I see day in and day out. Last night, my unit operated on 3 perforation peritonitis patients. I can't keep on waiting. When I'll get an interesting job, then only I will do it. I have to attend to what is important in my research. And finally, I asked my mentor, Professor Len, who is a Nobel laureate in chemistry in Strasbourg. I have met him many times and he has always given me very good ideas. I asked him, sir, what should I do when I don't have resources? He said, you write your own science. You create your own science. And what we can interpret easily as thinking out of the box. We don't have to think of what is given in the textbook. We can write our own science. So that is what we have to do. All of us have spent decades in this field, and we can certainly come out with some good ideas to solve our own problems, because nobody else will do it. They have expensive technology. They have all types of machines, good support from the companies. We don't have any of these things. So what is appropriate local technology which is available to us? No one asks me what I need. The company people, they come and they want to sell me something which is worth millions. I don't need it. Nobody asks me. It has to be available to me. It has to be cost effective. It should be easy to maintain. It must be transparent. Everyone should understand. And if I'm involved in its co-creation, I can repair it. I can manage it. And it should be transferable, easy to learn, easy to perform, and easy to teach. This is the type of technology or the surgical ideas which we want to propagate. When we talk about innovation, it is always a 3-legged stool, which gives you the balance. Balance is the most beautiful word in the English language. You cannot operate all the time. You cannot look after your family all the time. Whatever you are doing has to be balanced. So it has surgical precision, surgical wisdom, and patient safety, which can lead to a positive change. That is my definition for any innovation, a balance of all the good things. So let us start with a very simple and old idea of preventing peptic ulcer. Yes, sir, you are listening correctly. It is prevention of peptic ulcer, not treatment. Acid is produced in the stomach, but the ulcer is formed always in the duodenum because stomach is protected. What is the duodenal's protection against the assault of acid? It is the alkaline juices, the bile and the pancreatic juice. So if we can delay the acid from reaching here, the fire brigade would be ready. And how can we delay? If you don't take water with your meals, very simple old traditional ideas, maybe you have been taught by your grandmothers. Don't drink a lot of water with your food. All of us have been taught this. We share the same heritage. I'm sure our grandmothers have taught us this. So if you don't take water with your meals, the food will be solid and will remain in stomach for a longer period by the time this fire brigade is ready, and the ulcer will not form. This was a more than 25 years ago. I conducted this research and I was awarded my first doctorate on this, and it was published a long time ago. Very simple idea. Similarly, we have so many scoring systems devised by our Western colleagues. They involve usage of very high-tech things, arterial pH, blood gas analysis, which may not be available. For we have simplified the Apache scoring system for peptic perforation. We have simplified the scoring system for burns. And because I belong to Jabalpur, instead of labeling them with my name, I have labeled them with my city's name, Jabalpur Prognostic System and Jabalpur Scoring System for burns. Even without the use of expensive tests.
Professor, can you forward the slides?
Only first slide is visible to us.
Should I go back, sir?
Yeah, I think start from the first slide again.
Maybe if it is on slideshow, then it will move.
Yes, it is not in slideshow.
Ask him to turn it to slideshow.
Could you turn it to slideshow, sir?
Sir, it is slideshow.
It's not moving.
But it is not moving, sir.
It is moving on my screen, sir. Is this visible to you, sir, this screen?
Only first slide is visible to us, sir.
Okay.
This one?
Can you stop sharing and share it again with what you are having this slide show on? There would be two screens. One is with your PowerPoint presentation, and another is with the screen show, the slide show. So we need to stop sharing and share it again, please.
Share it.
Okay, I'll try that. I'll try that. Okay, I'm sharing the screen again. Is this slide visible, sir?
The first one is visible.
Only the first one.
Now?
No.
Not yet.
It is visible on my screen, sir.
Sharing
only the first slide. It is showing the friendship and goodwill and logos.
Okay.
That is visible.
Now this is the second slide.
We are unable to see the second slide.
Oh.
On the screen.
Can I be guided by some IT people there why the screen is not being shared? Because my screen share shows that I'm sharing. Should I try again, sir? I'll stop share.
Yes, sir. Now,
that is better.
Stop sharing and then start again.
Yeah, I have stopped sharing now, and I'll start sharing again, sir.
And share your desktop now, sir.
Okay, this is it. Can you see the slide now?
Yes.
So we can see the PowerPoint presentation. What you can do is to just forward the slides from here and do not use the slide share, the slideshow.
Okay.
Just
Okay, I'll
forward them
try
from
that.
here, sir.
I'll try that. Is it okay now?
Yes.
Yes.
That's fine, sir.
Now it's going on.
Okay. So, should I start speaking again, or?
It's okay, I think, from now on.
Yeah. Okay. So, like I had told you, this is our philosophy, trying to find a low-cost solution. Is the slide visible now, sir?
Yes,
it is.
Okay. So this I have spoken about the global and how I think that we talk it local, the global wisdom with the local resources. So first wisdom which we discussed was difficulties are opportunities, and this is great advice coming from Nobel laureate Joseph Murray, one of the few surgeons who received the Nobel Prize. Then the next one was we have to do research on what is interesting or what is important. So what is important for us, that is what we have chosen to focus on our energies on. So when I asked Professor Lane, who is one of my mentors, how to go about it, he advised me to think out of the box. What he called was create science when needed. Write your own science, write your own textbook. So this is the local technology we spoke about, which we have, what is available to us, what is affordable, what is easy to maintain, and we have to understand the technology which we are using so we can repair it. More important is if we are involved in its co-creation, we can take care of it, and it should be transferable. If I devise a surgery, it should be easy to learn, easy to perform, and easy to teach. Okay, sir, are the slides visible now? Should I go on?
Yeah, carry on, please.
Okay, thank you. So when I spoke about surgical innovation, it is all about balancing. So the balance has to be between the surgical precision, surgical wisdom, and the patient safety that can bring about a positive change. Innovation has been defined by many different definitions. This is the simplest definition for us to understand. Now, I was speaking about prevention of peptic ulcer, and the ulcer is produced in the duodenum, although the acid is produced in the stomach. And the protection of duodenum is the bile juices, pancreatic juice, which are alkaline in nature. If we can delay the food from reaching duodenum along with acid, this fire brigade would be ready, and it should be able to prevent the ulcer. It's a very simple idea. And like I told you, maybe your grandmothers have taught you not to drink a lot of water with your meals, wait for half an hour and then take a full glass of water. So this is a very simple idea which has been a traditional teaching in India, and I'm sure with you also, because we share our heritage. And I was awarded my first doctorate on this long time ago. So similarly, when expensive blood tests like blood pH, arterial pH, blood gas analysis, when they are not available, so we simplified Apache scoring system, and we removed all these expensive tests, and Apache still retains a simplified Jabalpur prognostic scoring system. Same thing for burns, Jabalpur scoring system for burns. Simple ideas, just see and remove all the expensive tests. Similarly, our patients are different. We need our own scoring systems for abdominal trauma and sepsis. We need our own POSM. POSM is a surgical audit system which is popularly used, widely used, but our patient profile is different. So when we had to modify, we called it Jabalpur POSM. Similarly, our lymph node counts are different. Lymph node counts are important. Everybody measures the quality of your surgery by the number of lymph nodes which you are removing when you are doing radical esophagectomy or gastrectomy. So our counts are different. We have plenty of peptic perforations. In about 5 to 7% cases, the perforation repair leaks, and we have a duodenal fistula. It's a very difficult situation because the omentum has already been utilized. The intestines are plastered because of the previous infection, and we don't have anything to repair it with. The jejunal serosal patch used to be popular, but if the intestines are plastered, patient's condition is very poor. What we do is we find that rectus abdominis muscle, which we use often for mobilization, construction of breast and all those things.
मैं कॉलेज जाता हूँ क्योंकि मेरे को डेंटिस्ट की अपॉइंटमेंट भी लेनी है, तो मैं अभी डेंटिस्ट की अपॉइंटमेंट चल रहा, तो वैसे भी फोरेंसिक्स वाला.
So what we use was, what is locally available is the rectus abdominis muscle. So we take the rectus abdominis muscle and suture it to the edges of the duodenal fistula. But our residents were struggling because this is a technically demanding surgery, especially the last couple of sutures in the right hypochondrium. So we simplified this operation. We took the muscle out. We asked the anesthetist to push the Ryle's tube through the fistula. We tied it, sutured it to the nasogastric tube, and then the anesthetist pulled it back and it went and plugged it. So it became a plug. Very simple surgery for duodenal fistula. Similarly, we still have lots and lots of typhoid perforations. And when we were repairing them 3 decades ago, we had a lot of mortality. Overall, every third patient we were losing. Every fistula, every repair which broke down ended in death of the patient. So what we did was we shifted to doing ileostomy in every patient, because we had very few surgeons and number of surgeries were being done by residents in the night. So a lot of patients had a defunction.
هذا توصل فات لكن نوزم اللي ياخذ يجي كتسيك نتسيك كسكره سي بيتو سي بريميو بيا.
So all these patients, they started surviving, our mortality went down to less than 3%. Only those patients who were already in septic shock, we lost them within 24 to 48 hours. After that, there was no death. So very simple idea, ileostomy in every patient of fecal fistula. Now, when we had a lot of these stoma, we didn't have expensive stoma care. So one of my patients taught me that he came with such beautiful skin, and he taught me that he was using linseed oil. Linseed oil has been used in every civilization in the history for its medicinal use. I did not know. The word liniment comes from linseed, and we have since then been prescribing it. It's very simple. Rural area patients, they have great acceptance because traditionally they know about its medicinal property. So patients with upper GI bleed, for a long time, we did not have an upper GI endoscope. So if patient had ascites, we started measuring their serum ascites albumin gradient. It reflects the portal hypertension. The higher the gradient, higher is the possibility that patient has portal hypertension. Even the smallest lab can measure serum ascites and serum albumin. Very simple idea. We wanted to do transthoracic esophagectomies. Again, the lack of ventilators prevented us. So we started doing transhiatal esophagectomy. And every time I'll put my hand in transhiatally to dissect the middle part of the esophagus, I'll end up compressing the heart. And my anesthetist will start shouting at me, remove your hand, the blood, the cardiac output is falling, the pressure is falling. So one of my residents came with this idea, devising a ring stripper. Can you see it is a ring attached to a handle? And we started inserting it from here. And within 1 minute, we were able to strip the esophagus. And we have done more than 200 of these cases in last about 20 years. And it's a very simple technique. Although initially you may be reluctant to use because you are putting a metal instrument blindly in the thorax, but it sticks to the wall of the esophagus and it is very easy. We don't have staplers. Even today, we struggle to buy staplers. For devascularization in portal hypertension, we use a simple technique of transmural sutures. You can see this is the Ryle's tube and the transmural suture, which takes care of 2 layers of sutures, which ligate all the varices. Similarly, for very low anterior resection in women, we have a lot of space in the perineum, and we can give incision here. Finish the total mesorectal excision from the top, take the rectum out here, transect under vision, and make the anastomosis under vision. So, perennial approach, low anterior resection. Just a reminder about Alexis Carrel, another surgeon who received the Nobel Prize for his vascular anastomotic technique. Incidentally, he learned it from embroidery from his mother. So we also thought that if we can come out with some suturing techniques, we also visited this idea. And I have a very smart girl working with me as an associate professor. And we were able to devise 2 simple suturing techniques. One is endoloop sutures, which we borrowed the idea from tatting, lace making, and another from knitting, knitting sweaters. So we borrowed this idea of herringbone sutures, which is very good for abdominal closure, and our hernia rate went down, incisional hernia rate went down.
Can I just interrupt for 1 minute? That
yes, sir.
after 2-3 minutes, we'll go off the air and offline, and please rejoin. Everybody rejoin again after 2 minutes.
Sure, sir. You want me to stop here and wait for that, or should I continue till that time?
Continue with it, and once we're offline, and then you can rejoin.
Okay, sir. Okay, I understand. We must be running out of time for this session.
That's right.
Exactly.
Okay, sir.
40 minutes, and then we'll have another 40 minutes afterwards.
Right, sir. Right, sir.
Thank you.
So for auto transfusion, for hemothorax, or for hemoperitoneum, we just drain the blood in an ordinary bag, which costs less than 200 rupees. We then just turn the bag upside down, you can see here, and use it for auto transfusion. Very simple, economical idea. This everybody knows. When the non-absorbable mesh is not available, which may be out of bounds for some patients, you can use, of course, a mosquito net. We have shown it experimentally. We have shown it patients that it is very easy. You buy one mosquito net for about 200 rupees, and you can have hundreds of meshes made from this.
That's very interesting. Now, how do you sterilize it, sir?
Sir, we use gas, sir.
I don't know.
We can use gas. You can put it in formalin, sir, and at the end of the surgery, I pour 1 cup of betadine also in it.
Oh,
I always pour a cup of betadine in all my surgeries, sir, because we started in the era of antisepsis, and even today I am afraid to use the word asepsis in our operation theater. I don't know if it works or not, but it is.
Yeah, I wonder,
yes,
what was the percentage of infected these nets?
No infection, sir. More than 20 or 30 studies are now available from all over the world, sir, that nylon mosquito net works as well as an ordinary mesh, commercial mesh. More than 30 studies, sir. Now there are meta-analysis, there are systemic reviews. Everything proves that it is as good as an ordinary.
Resident no है
इन्होंने चैप्टर भी लिखा है टेक्स्ट बुक ऑफ सर्जरी में on this. Right, sir, we are back to normal.
Okay, sir, I'll start sharing the screen again.
Right.
Sir, you have to give me permission because I'm not being allowed.
Sir, please try now.
Yes. Okay, is it visible now?
Yes.
Okay, we were here, sir.
Carry on, please.
Yes, sir. I'll just finish that part. I'll just finish that discussion, sir. Now, thousands.
May I request if you can share those studies with me of the ordinary net being used for herniorrhaphies?
Sir, I will email to you, and many studies from India and Africa and even in developed countries, sir.
Okay, thank you very much.
And one of my colleagues from Imperial College in London, he has written a very good review article on this, that how well it works and why it is known as reverse innovation, sir. Right. When some innovation takes place in a developing country, but the developed countries are very reluctant to accept it because they feel that it is not good enough. I have written an editorial on it, sir. I will share that editorial also with you.
Okay, okay. Thank you.
Sir, going on to the next one. So, if you come across a strangulated hernia, Now, how do you repair that? Strangulated, you have gangrene, you have resection. So traditionally, the books advise that you use an absorbable mesh, which is quite expensive and not available with us. So we have shown that non-absorbable mesh, ordinary Prolene mesh can work and it is safe. And we, like I told you, sir, perforation peritonitis is very common. Large number of our patients were ending up with burst abdomen and incisional hernias. So we have shown that non-absorbable mesh is safe even as a preventive measure. And for peptic perforation patients, we have shown that non-absorbable mesh can be put in as a prophylaxis against burst abdomen and incisional hernia. So even that works. So they are safe. We have a busy plastic surgery unit and skin grafting solutions, couple of them. The traditional wisdom was don't do a skin graft if the hemoglobin is less than 10 gram%. But we have shown that normovolumic anemia takes the graft, and even as low as 6 gram% anemia, you can graft and the graft will take. Similarly, we have a cadaveric allograft program, and cadaveric allograft program, we can increase the rejection time if we remove the epidermis, because epidermis contains all polygenic elements. And if the epidermis is removed, only dermis is grafted, the graft take increases by 7 to 10 days. Very simple idea. Just remove the epidermis. So for pediatric laparoscopic surgery, sir, for anorectal malformation, traditionally the ileostomy is made in the left iliac fossa. And when the second stage of repair is actually done, this interferes with surgery. So we shifted lateralized the sigmoid colostomy to the flank, which is easier to manage also with a stoma bag. And now we have all this space here for second stage surgery. For the same type of problem, sir, if you want to avoid a colostomy, you have a distended sigmoid colon here. So the first stage can be combined. We put in a perennial intracath and lavage and wash the meconium away. So the sigmoid collapses, and in selected number of patients, this stoma can be avoided. Transperineal intracath muconolysis and evacuation. So simple idea which has worked for us. We have a lot of patients of Berger's disease, thromboangiitis obliterans because of smoking, all coming from very poor socioeconomic strata. So these small ulcers, non-healing ulcers and cutaneous gangrene, we use platelet-rich plasma. We take 30 ml of patient's own blood, centrifuge it twice, and the PRP which results, that can be injected. On day one, the pain subsides by 50% because platelet-rich plasma is a storehouse of growth factors. Even big ulcers, they start healing. This patient has lost number of toes. He underwent lumbar symplectomy, then underwent omental transposition. Then we grafted, nothing worked. But once we injected the PRP, even this ulcer, non-healing ulcer, started healing. Simple idea, use of platelet-rich plasma. We have a lot of patients of Hansen's disease, leprosy. It is considered politically incorrect to use the word leprosy, but for ease of communication, leprosy, Hansen's disease, and also diabetic foot. They lose the sensations in the sole, and they have these trophic ulcers which don't heal. Surprisingly, in both the diseases, Hansen's as well as diabetic foot, the nerve which is affected is posterior tibial, and the saphenous nerve which is nearby is somehow not affected. So what we did was we transferred the saphenous nerve to the posterior tibial nerve, and over a period of 3 to 6 months, the sensations appeared on the sole, and as a bonus, the ulcer started healing. Both of these have been published in a very highly cited journal, and very simple operation. Your plastic surgeons who are used to neuronal repairs, they can do it in 30 minutes.
Good idea.
Good idea. One of the problem.
Very good idea.
शर्मा साहब का लिंक ड्रॉप हुआ था, लिंक हुआ नहीं, इंटरनेट का कोई इशू है, बाकी लोग जो आएंगे
I must say there are a lot of thinking goes into it. Very simple things and
और ये बड़े प्रॉब्लम है।
तो मैं फोन पे राब्ता करना है, राब्ता करना चाहिए क्योंकि इधर से तो राब्ता नहीं हो रहा। वो शायद पढ़ा रहे हैं।
is back. Back now. Yes. Okay.
Sir, I'll start sharing my screen again.
Okay. Okay.
Sir, is it visible now?
Yes, it is.
Okay. So for evacuation of bladder, either they have a continuous catheter or intermittent self-catheterization. Both have the risk of sending infection and kidney damage. And many patients they die of renal failure after 2-3 years of their traumatic paraplegia. So what we did was we dissected the bladder, and because we are used to taking out the rectus abdominis muscle, we took the rectus abdominis muscle, dissected it from the top, cut it, and then the upper end was wrapped around the fundus of the bladder like a pagdi, like a turban. Can you appreciate this? Like a turban, like a pagdi. So after 2 weeks, when we removed the catheter, patient
That's wonderful.
This patient is passing urine after 2 years.
Right. That's a very good idea.
So you have seen the patient passing urine after 2 years, good flow, and you can hear my house surgeon in the background asking him to strain. You know, just like exercising the abdominal muscle, he's contracting the abdominal muscles and good amount of urine with a good flow. So again, a simple idea.
Very good.
So then, sir, we had this pandemic, COVID came, and everybody was worried about the droplets, and they started talking about negative pressure flow in the operation theater. Everybody was afraid, the anesthetists were afraid, the surgeons were afraid, and for quite some time, routine surgeries were shut down. So we didn't have the money to buy all these fancy filtration equipment for our operation theater. So what we did was, we just put in a exhaust fan, big exhaust fan, and started using it. And we have had no issues since then. It was published in BJS, and very simple idea, just put in a big exhaust fan, evacuate all the air routinely from the operation theater. COVID also brought fungal infection called mucormycosis to us. And we had number of patients whom we had to evacuate their eyeball. This was routinely how the ophthalmologists were doing orbital exenteration. They were removing the eyelid. We suggested that don't remove the eyelids because that will ensure we have good cosmetic appearance. In this, even when an artificial eyeball is fitted after 6 months, he will not have any eyelids and very poor cosmetic appearance. So what we did was, since the infection was coming from inside the nose, the eyelids were spared. So we retained the eyelids and exenterated the eyeball. And now what you can see, when this patient will be fitted an artificial eyeball, he will have the power of his eyelids because we'll do surgery and anastomose fasciolata here. So total eyelid sparing, eyelid complex sparing. This is what we have suggested. It has worked for us. all of us do maxillomandible fixation. Lot of people use stainless steel wire. But if you use stainless steel wire in the ward, if patient has vomiting, especially head injury patient, you have the risk of regurgitation and aspiration. So many of us use rubber bands. The commercially available rubber bands may not be available. So what we do is, this is the injection port of the infusion set. If this can be cut, we have small rubber bands indigenously made, and they can be fixed to give a good occlusion of maxillomandibular fixation. Rubber band made from cutting off infusion port of the ordinary intravenous. So, sir, this is our motto. We modify, we simplify, and then we apply. If you will remember the philosopher of 16th century, Occam suggested that if there are many explanations for one phenomena, the simplest phenomena is likely to be the correct one, the simplest explanation. So we try to find the simplest solution to our problem. And as it happens, the simplest solution is also the most economic one. And like everybody's favorite Nobel laureate Einstein said, when the solution is simple, God is answering our prayers. So we have been lucky. God has answered many of our prayers, and I have shared some of those successful ideas with you. This should be the response when somebody else hears about it. Such a simple idea, why didn't I think of it? So that is the beauty of the simple ideas. Don't think that we don't take permission from the ethical committee. It is the dictum when the evangelists are operating, the skeptics have to form the ethical committee. So we are the evangelists, we try to form, I believe we are doing God's work, but we have to have institutional ethics committee. They are our safety for us as well as for our patients. So we need these skeptics, and sometimes simplifying the operation is easier than convincing the ethical committee. We have the ethical committee meeting twice a year. So sometimes we have to wait. They give many suggestions. So we simplify the operation further. And then the second time we get the permission, only then we go ahead. So don't think that this is what our route has been. Our road has been something like this. And we learned from Edison, who invented the light bulb after 1,000 attempts. And when his friends used to tease him that you have failed 1,000 times, he always said that I know 1,000 ways by which the light bulb does not work. So similarly, sir, I know many ways by which surgery does not work. And today I have shared some of my successful ideas with you. This is one question why I am frequently asked, why we are able to have so many innovating ideas and why we have more success. Sir, we have a general surgery department. We have many specialties. All are inside the department. We don't have separate units. All these, there are no silos, no separate units. Everybody attends the same PG class. We sit in the operation theater together. So we have cross-fertilization of the ideas. And there is a very good team spirit, very healthy rivalry. We celebrate each other's successes and we mourn each other's failures. So we are together in this. So this is our innovation ecosystem. And I encourage my young minds, residents, registrars, because they have the greatest fertile minds, youngsters. As we grow older, our new ideas rate becomes less and less. So we are used to finding a solution, because I encourage even my junior resident to come and tell me if he thinks some idea can work. And this is my role, to provide them, to protect them, to encourage them. You know, in any hospital, especially in a government teaching hospital, there can be sometimes a lot of politics, a lot of negative emotions, lot of negative vibes. So it is my job as the head department to protect them from all the negativity and give them a platform where we can find a solution. So, sir, that is my role. If you are interested, you can find all my ideas. They have been published. Links to all the publication are on this webpage, www.surgicalinnovations.in. And I always conclude, sir, you have heard me speak many times. Everyone speaks about value for money. I always speak about value for many. Millions of our poor patients survive on less than 200 rupees per day. We have to do research for them. They have to be included. Sir, this is our duty. All of us are God-fearing people and we are working for God. I'm doing God's work. So this is our duty to be honorable and generous towards the underprivileged who are less privileged than us. And we have to do it gracefully without being condescending. Because if you want to lead, you have to serve. There is no ruling in leading. You have to serve. Thank you very much, sir.
Very kind. Thank you very much. Well, I think we will encourage people to ask questions, and I have Professor Meshwani from Peshawar with us, and Professor Razak, and please do ask any questions, or the audience here. I'm sure Professor Sharma would be very happy to answer. Welcome, Professor Abdullah from Karachi. And please, if there is any query or question or comment, go ahead with it. Thank you.
Sir, just one question regarding this use of betadine in every case while using this mosquito mesh for surgical repair. Are they using the betadine solution which is used for hand wash, or what type of any special preparation, any special concentration?
No, sir. Betadine, which is used for dressing, sir. I'm afraid that is my weakness. When I started 40 years ago, sir, we did not have good antibiotics. So this is just something which I do in every case, sir. I pour a lot of betadine before I close the skin. There is no, maybe there is no scientific basis. It is my weakness. I think betadine is our friend and it will take care of the infection.
Yes, this betadine kills every known germ.
Sir, I don't know if you use this word. I call it my totka, sir. Totka, do you know totka?
We do know totka. Okay.
Totka, something like a good lucky charm. Totka.
Right.
Lucky charm. So I put betadine in every wound.
Right. Any questions or comments from anybody? Please go ahead with it. Professor Sharma is here. We have got a few more minutes left.
Yes, sir.
Okay. Please ask any question. Abdullah, you have any? Abdullah, go unmute kar de. Any questions for Professor Sharma? Sir, I mean, Professor Sharma has also written a chapter on this in the SARC textbook of surgery, which is ready. Professor Sharma, I went to Sri Lanka and asked them, there are 2 chapters remaining from Sri Lanka, and they are
okay.
And once we have it in hand, I have requested Professor Santosh to talk to JP Brothers if they can publish our book, because the number of colleges in India is about 600. And, we'll have, or else we have one publisher here, Paramount publisher, who is ready to do the job. Professor Sharma has contributed there as well in that SARC textbook surgery on these innovations. I think it's very important in countries where we don't have many resources. I think if you can save money, one should honestly, like a mesh in Pakistan would cost about 10,000 rupees. Yeah, and in India, probably it will be 5,000 rupees. But I think if you can have it without any cost, for poor patients, it's a very, very good idea. But I think the best idea that I liked was this turban, urinary bladder turban. I think it's amazing, honestly, because there is no other solution other than catheterization, intermittent or continuous, and then bladder infections and whatnot. So I think some great ideas you have put into practice, and we have these young people here. So I think the way I look at your presentation is that it's a food for thought for youngsters. They should continue to search for such ideas. I think that's where lies the strength of this presentation.
Sir, I must share a couple of my personal experiences with this innovation and these things. In a remote area, as you know, I have been serving in remote areas in the AJK and Balochistan and Anterior Sindh and areas where there is fancy things are not available at all. So why came to me with a fracture, very bad fracture. So of the radius, I had no other thing, no implant. So I used the simple metallic wire of this bicycle wheel spoke or whatever it is called. And after, as you know, in young children, the fracture heals very rapidly. So I removed and there was no infection and it worked very well. Similarly, in vascular injury, as you know, at times one cannot do the repair or the things are not available. When I was a young major and I had no experience of the vascular surgery. So I used to use this simple, this drip tube, polythene tube as a temporary shunt, and then transferred the patient to this CMH. And luckily it was an officer, he was an officer, and the limb was saved with this simple polythene tube of this drip. So we can use these things in such circumstances.
I think, sir, they are both wonderful examples of human ingenuity and what our mind is capable of doing, sir. And if we have the ability to think on our feet when we are faced with a difficult situation, we should encourage our youngsters also to think like that, sir. Everything is not given in textbooks, sir. Sometimes we have to improvise and innovate.
Very good idea. Very good idea. I think we have also done that. Speak louder.
I've done one innovation. I've been doing it for the last 4 years now. We bought the equipment for hemorrhoidal artery ligation and rectoanal repair in the year 2014. And the cost of that for one procedure was around 10,000 rupees, Pakistani rupees. And when the dollar rose in price, so it was not affordable for the patient. So what I did was, instead of doing it with a hemorrhoidal artery Doppler machine, I started doing it without that. And we used to ligate at 3, 7, and 11 o'clock position and do a mucopaxing. And the results are comparable what we did with the Doppler probe. And I've written an original article, and that is in the process of publication. I've done around 200 cases without Doppler. And there is only one recurrence in the last 4 years. So it has worked very well.
That's a very good idea, sir. And we have to publish. I have a couple of slides which I deleted because of lack of time. But sir, unless we publish, nobody notices us, sir. Yeah. I will use a sentence in Hindi. Probably it is same in Urdu also, sir. So I'll just say, otherwise, sir, jungle mein mor nacha kisne dekha? Absolutely. All of us are doing, sir, great work. And because we don't publish, this is something we have to inculcate in our youngsters, that every idea has to be validated and published.
Right.
And actually, sir, that is the purpose of science. Purpose of science is to publish. And I'll elaborate on it, because whatever you have done, unless it is accepted by your peers, it is not going to be published. So it is the peer acceptance. What you are doing has to be accepted. That is the purpose of science. Otherwise, if, sir, we claim that 2 + 2 is 6, nobody will accept it.
Yes.
We have to prove it to the satisfaction of our peers that 2 + 2 is 6. If we can prove that, it's published.
Right. Very nice. Any other questions or comments from it? Ji.
Sir, I would like to ask a question. Have you used the PRP in other ulcers as well?
PRP in?
You told us that you use the PRP in the Burgess diseases ulcer. But have you used other ulcers as well?
Diabetic ulcers, it is being used.
So what are the results do you see? In
Very good results, sir. You will find many publications on diabetic ulcers, and you just go to PubMed, write PRP and diabetic ulcers, and you will have, I think, more than 5 or 10 articles. You can use it in diabetic ulcers also.
Okay. Thank you, sir.
Well, if there are no questions, I would like to thank Professor Sharma for being very kind, and he's such a great educationist that he's always there. He said, just give me a day and, he'll... So, sir, I think what we'll do is that we have in Pakistan now a time that all the students have gone home for preparation, and the faculty. So we are doing a lot of faculty training programs here in our institution, and we will continue to bother you every couple of weeks. And
no problem, sir. You have my power of attorney for any educational activity, sir. You just tick my name. I'll be there.
Very kind, and God bless you. And everybody enjoyed the talk, and thank you very much. Yeah,
thank you very much, sir. Thank you very much, sir.
Wonderful. Thank you very
much, sir. Thank you, sir.
Okay. Okay, Mishwani Saab or
Allah Hafiz, sir. Thank you, sir.
Saab or Abdullah Saab, very kind of you, and Samreen Jameel for joining us. And I think we are going to make it a regular feature that, we invite Professor Sharma. He's a great friend and, very simple man. And look at the innovations that he keeps on doing and keeps on developing. And the interesting thing is that he has had all these published at the international level.